Okay, so again, we have Happiness presenting for us this morning as she's preparing to defend her thesis at the KCMC University. So without further ado, I will hand it over. Please take notes. Feel free to share questions as we go through. Carrie, will Happiness.
Thank you. So good morning and good evening, everyone. My name is Happiness. I am a TREC trainee, a part of the second cohort. So I'll be sharing with you findings from my research dissertation. So to begin, I'll turn off my video to present my work, and then later on in the comments and questions section, I think I'll put back my video. Okay. Please let me know if you can all see my screen.
Yep, it's great.
Okay. So for my research dissertation, I've been working on looking at the association between hospital arrival time and functional outcome among referred pediatric injury patients at KCMC. And this is a retrospective cohort study from 2020 to 2024. So this is going to be the outline of my presentation. And these are the acronyms that I've used. To begin with the definition of key terms, so standard definitions, pediatric injury refers to physical harm to a child aged less than 18 years caused by external factors, including unintentional events like falls and burns, or intentional acts such as violence and abuse, potentially leading to disability or death. Glasgow Outcome Score Extended Pediatrics. This is a structured external assessment tool that is used to evaluate a child's functional capacity following injury. And it is a score that ranges from 1 to 8, 1 being up a good recovery to 8 being death. In operational definition of terms for this study, hospital arrival time will refer to the duration that is measured in hours from the time a pediatric injury patient arrives at the initial or referring healthcare facility to the time they arrive at KCMC Emergency Medicine Department. And functional outcome in the study refers to a child's level of recovery and ability to perform daily activities after an injury. And for the purposes in this study, it is measured using the GOS-E-PIDS, which will be used to assess functional outcome. And for analysis purposes, the outcomes will be dichotomized as follows. A good functional outcome will mean children who scored a GOS-E-PIDS of 1 to 2, and poor functional outcome for those who have a GOS-E-PIDS of score of 3 to 8. So globally, about 4.4 million people die due to injury, and 13% of these deaths are reported to occur among children and adolescents, but also injury has been reported as a leading cause of premature and preventable death among children worldwide. Children living in low-middle-income countries are reported to experience about 8 times at risk of unintentional injuries compared to those living in high-income countries, and about more than 95% of all pediatric injury-related deaths are reported to occur in the low-middle-income countries, with sub-Saharan Africa being disproportionately affected. In the case of Tanzanian context, 25% of all injury-related admissions were attributed to pediatric population. And a study that was conducted here in northern Tanzania, a facility-based study among pediatric injury patients, they did report a mortality rate of about 8.2%, which was relatively high compared to other pediatric registry studies that were conducted in sub-Saharan Africa countries, which reported a range of mortality from about 0.7 to about 6%. So we see that most survivors for pediatric trauma or injury, they often face long-term functional impairments, which may affect their development as well as quality of life. And for mostly, access to timely and definitive care is critical to improve trauma outcomes, but yet these time intervals between injury, referral, and patients getting to tertiary care vary widely in the low-middle-income country setting. In Tanzania, some studies have been conducted to see the time it takes for patients to reach tertiary care. And for instance, a study that was conducted at Muhimbili, they reported a median time from injury to hospital arrival being 6 hours, about 6.3 hours. And with over 54% of patients who were polytrauma patients arriving after 6 hours. And a study that was conducted here at KCMC, they noted a median time of arrival of about 10.2 hours for those that were first initially seen at clinics, and about 8 hours for patients that had facilities visit as district or regional hospitals. So there are different divergent findings in literatures concerning time to arrival. So we see that longer times to definitive care, other studies have reported to be associated with poor functional outcome. And others have tried to report that for less severe injuries, most of them are referred more later and they still survive. And this may lead to apparent survival benefits with longer times due to referral bias or sometimes confounding by severity. However, these findings are mostly evidence from high-income countries, and the focus has been primarily on looking at mortality as a measure of outcome. And most studies have either focused on specific types of injury or just adult population. So in this diagram, we see a conceptual framework. This has been adapted from the Donabedian structure process outcome model, which is used to conceptualize pathways to reach structural and procedural health system elements, influence the functional outcome of referred pediatric injury patients. And within this framework, we see that there are structural and process factors that converge to shape the timeliness of care. Specifically, the hospital arrival time, which we speak of the time from referring facility to arrival at KCMC, which is the study's main exposure. So we see we have some structural factors, including like referral facility type, form of payment, distance from initial facility, and some of the process factors that may influence hospital arrival time, being time taken from injury to the initial facility, the care received from referral facilities, as well as the mode of transport. And hospital arrival time also has been reported to be associated with poor functional outcome at discharge, but we still have a myriad of factors, both social demographic and clinical factors, that we know have been reported to be associated with the outcome of interest. So we know that timely access to referral care is essential for improving recovery in pediatric trauma cases. And in many LMICs, referral systems are still fragmented and inefficient. And some of the barriers that are reported include long transport distances, inconsistent or delayed peripheral stabilization, as well as multiple interfacility transfers. But also, these delays can be linked to increased complications for patients, but also long hospital stays and poor functional outcome for children. However, in sub-Saharan Africa, there's still limited body of evidence where we see very few studies that focus on only referred patient, and hospital arrival time is rarely analyzed as a key determinant when it comes to functional outcome. So all of this can lead to a hamper local data that is important in the development of effective triage protocols, as well as design of responsive referral networks in settings like northern Tanzania. So this led to the objectives of my study, which the broad objective was to examine the association between hospital arrival time and functional outcome among referred pediatric injury patients at KCMC, and my specific objectives being the first to compare the rates of functional outcome across both social demographic and clinical characteristics among referred pediatric injury patients, and the second one being to determine the association between hospital arrival time and functional outcome among referred pediatric patients at KCMC. So in my methods, beginning with the description of the data source, this study employed the KCMC Pediatric Trauma Registry, which was a prospective cohort design, and it was conducted, it initially began from November 2020 with the aim of providing insights into epidemiology, clinical presentation, and hospital outcomes of pediatric injury patients. And it recruited patients less than 18 years of age who had experienced injury and sought care at the EMD for their injury. And data collection was collected using standardized electronic questionnaires by trained RAs. In this current study, this is a retrospective cohort study, and the study period is from November 2020 to July 2024, conducted here at KCMC, and the study population being all injured patients that are less than 18 years of age. And I included pediatric patients who were referred for injury care at KCMC from other referring facilities. and I excluded patients who had sought care directly at KCMC without prior visit to any intermediary facility. So in this figure, we see that this is the patient selection flow chart for pediatric injury patients from the KCMC Pediatric Trauma Registry. So the registry from November 2020 to July had a total of 1,058 patients. 184 patients were excluded who came directly without prior visit to an intermediary facility, and making a total of 874. 6 patients were excluded who had missing discharge date and time, as well as 1 patient who had a missing outcome, making a total number of patients which were included in the survival analysis being 867. So the power of study was calculated using the formula for 2 proportions by Kirkwood and Sten, and the study had an overall power of 99.9%. So describing my study variables, so to begin with the dependent variable, so as I mentioned earlier, functional outcome at discharge was the primary outcome of interest. And for this study, it is measured using the Glasgow Outcome Score Extended for Pediatrics, which is a standardized tool with 8 levels from 1, upper good recovery, and 8 being death. And for analysis purposes, the GOS-E-PEDS scores were dichotomized from score 1 to 2, being good functional outcome, and score 3 to 8 being poor functional outcome. And dichotomization has been reported as the widely used approach for analysis of GOS-E, as it enhances statistical interpretability. And in the survival analysis, poor functional outcome was the event of interest, while patients who had a good functional outcome were treated as censored observations. So in the independent variables, I have the primary exposure being hospital arrival time, which is defined as the duration from arrival at the referring facility to arrival at KCMC. And the time was modeled both as continuous and categorical in my models, and the categorization based on 6-hour cutoff point. And this was first, we know that in Tanzania, there are no standardized national cutoff points that exist for defining referral delays. So the 6-hour threshold was adopted as a proxy based on a study that was conducted at Muhimbili, but also the median time from injury to arrival at KCMC was 6 hours. So this also made a basis as to why the 6-hour cutoff point was chosen. And as I mentioned, also hospital arrival time was modeled both as continuous and categorical in the regression models. Other independent variables span from social demographic characteristics, pre-hospital and injury characteristics, as well as clinical characteristics. And the follow-up time was modeled from the time of injury to time at discharge at KCMC, because the GOS-E-PEDS is measured at discharge for patients, for pediatric injury patients. So data cleaning and analysis was conducted using standard version 18, and descriptive statistics were summarized using median and interquartile range for continuous variables, frequency and proportion for categorical variables, and Pearson chi-square tests were used to compare poor functional outcome proportion across social demographic and clinical characteristic groups. Kaplan-Meier curve were used to visualize survival probabilities over time. But also log rank tests were used to assess group differences, and Nelson-Allen plots showed cumulative hazard over time. Incidence rates with 95% confidence intervals were calculated, and the median time to poor outcome were compared across categories. Assumptions, first, the proportional hazard assumption was assessed visually using the log-log plots and the Schoenfeld residuals, both global and covariate specific, which was significant, and the proportional hazard assumption was violated. For multicollinearity, it was checked using the variance inflation factor, where all predictors had a VIF of less than 10, with the mean VIF being 1.58, and hence there was no multicollinearity. In model building, univariable Cox models were assessed crude association, where variables with a p-value of less than 0.2 or prior support from literature were included in the multivariable models. And I compared 3 models: the Cox proportional hazard model, the Weibull and exponential model, and AIC and BIC were used for model selection. And from the table, we see that the Weibull model had the lowest AIC and the lowest BIC. So the Weibull model was selected, but also the assumption of monotonic increase was checked, and it was met for the Weibull model. So model fit was done using the Cox-Neil residuals used to assess the goodness of fit, and the Weibull model had fit the data well compared to the Cox and exponential models, which showed visible deviation from the 45 degrees line. Ethical consideration was obtained from the Research Ethic Review Committee, number PG177, and in the plan of dissemination, findings from the study will be shared at the KCMC library, at conferences, as well as through publications. So in my results, beginning with the social demographic and clinical characteristics of referred injury patients, we see that the median hospital arrival time, that means from the time of initial facility to the time they got at KCMC, was 8 hours. And we see that about 59% of patients arrived greater than 6 hours. And when it comes to the time from when they got an injury to them getting to the initial facility, we see that the median time was about 0.8 hours. And we see that most patients, about 59.3%, arrived within less or equal to 1 hour. But also we see that the overall time from injury to the time they get to KCMC, the median time was 6 hours with an IQR of 3 to 15. And we see that most patients were school-age patients, 6 to 12 years, about 40.3%. And we see that mostly were males, 65.2%. And most of these patients came outside of Moshi, which comprised of 54.6%. When it comes to mode of payment, most patients paid by cash, 82.5%, and falls as well as road traffic injury being the most common mechanism of injury. And when it comes to the Glasgow Coma Scale, we see that most patients had normal GCS of about 84.1%, and about 4.3% had severe impairment. And most of patients were referred from health centers, dispensary, or clinics, making up about 45.1%. When it comes to the modality of transport, most patients came in through ambulance, which made up 64.1%. And we see that about 44.7% required surgery, and about 11.5% needed ICU admission. And of those that arrived at EMD, about 34.8% received immediate intervention. And about 4.3% had experienced complications, and only 3.5% had comorbid conditions. Looking at the objective where I wanted to look at the rates of poor functional outcome and the median time to poor functional outcome across social demographic and clinical characteristics. So we see for hospital arrival time, the incidence rate was high for those that came in less or equal than 6 hours, with an incidence rate of about 35.5, and a short median time to poor functional outcome of about 17 days. And for those that were able to get to the first initial facility within 1 hour, the incidence rate for poor functional outcome was about 28.9, and with a short median time to poor functional outcome being 20 days. And then also looking at variables like when it comes to mechanism of injury, we see that those who had falls as well as road traffic injury, they had the highest incidence rate for poor functional outcome and shorter median time to poor functional outcome compared to other mechanisms of injury. But also for patients that had severe impairment in their GCS, we see that they had about 42.1% higher incidence rate for poor functional outcome and a short median time to poor functional outcome compared to other GCS scores. Similarly, for patients that came in through ambulance, we see that about 28.2% incidence rate and a short median time of arrival compared to other modalities of transport, being 20 days, as well as for patients that had received surgery, we see that their incidence rate to poor functional outcome was about 35.9%. I mean, 20.6%, sorry. And their median time to poor functional outcome being 29 days. I think I should put some brackets for easy follow-up. My apologies. And for patients that had immediate intervention, we see that those who did not receive immediate intervention, the incidence rate for poor functional outcome was high compared to those who received intervention, with the incidence rate being 27.5, and the median time to poor functional outcome for those that did not receive immediate intervention was 22 days. So in figure 3, looking at the, we see that this is the overall KM curve that shows the cumulative probability of a patient remaining free from poor functional outcome over time among patients that were referred here at KCMC. And we see that the probability of remaining free of poor functional outcome over time decreases. And the median time to poor functional outcome, the overall median time was 22 days. So in this table, we see that this is the crude and adjusted hazard ratios for predictors of poor functional outcome among referred pediatric injury patients at KCMC. So we see for hospital arrival time, in this model, hospital arrival time was modeled as a continuous variable. So we see that for every additional increase, for every unit increase in time, we see that the rates of poor functional outcome decreased by 7%, which was significant. And also other variables that showed significant association with poor functional outcome included whom the patient lives with, where we see that for patients who live with both parents, they had about 30% lower rates of poor functional outcome compared to those who live with single parents. And also for patients that use insurance as a modality of payment, they had about 1.47 times higher rates of poor functional outcome compared to those that paid by cash. But also other factors that were associated with poor functional outcome included patients who had a severe impairment by their GCS score. We see that patients that had severe impairment compared to those who had normal GCS, they had 2.5 times higher rates of poor functional outcome. But also when it comes to patients who were referred from either regional hospitals, national, or specialized, we see that they had about 1.4 times higher rates of poor functional outcome compared to those that came from health centers, dispensaries, or clinics. But also we see other factors, including those who had arrived with ambulance. We see that they had about 2.3 times higher rates of poor functional outcome compared to those who used public transport. But also for patients, for other protective factors, we see that those who had received surgery or had received immediate intervention, they had lower rates of poor functional outcome. And for patients that had comorbid conditions, we see that they had 2 times higher rates of poor functional outcome compared to patients who are referred with no comorbid conditions. So a summary of the discussion. So we see that hospital arrival time was significantly associated with functional outcome, although this paradoxical longer time from referring facility to KCMC was linked with lower rates of poor functional outcome, where we see that every additional hour in hospital arrival time decreased the rate by poor functional outcome by 7%, which in other studies, this may be contradictory because other typical trauma care principles, we know they emphasize that early access to definitive care improve outcomes. So looking closely into the data, we see that findings in this study showed that the median referral time from patients getting from the first facility to KCMC was 8 hours. And this was similar with other low middle income countries, which reported a range of referral time from about 6 hours to 8 hours or greater. And it is in contrast to other high income countries, which have reported median times of arrival to definitive care or referral tertiary facilities to be about 3 to 4 hours. In this study, we see that about 59.3% of children had arrived at the initial facility within 1 hour, which different studies have tried to note that this to be called the golden hour or the golden opportunity, which is typically linked with better survival outcome in trauma care. And about 40.5% in this study had reached KCMC within 6 hours of injury. So for both times, for those who had got in the initial facility within 1 hour, and for those who came to KCMC within 6 hours, we see that in the in the table where we showed the incidence rate and the median times to poor functional outcome, they both had higher incidence of poor functional outcome, and they had a shorter median time to poor functional outcome, which this can try to explain that there is confounding by severity, where severely injured children were more likely to be triaged and transported faster, but still had worse outcomes. And we see that also in this study, the children who had severe impairment, that means who had GCS of about 3 to 8, they had highest incidence of poor functional outcome of about 42.1, and they had the shortest median time to poor functional outcome of 14 days. And other studies have tried to explain that for mostly severe injured children, they die before reaching the referral centers, which may lead to survival bias in hospital-based studies because we fail to capture this huge population of children that they were severely injured, but they couldn't make throughout the whole process or the whole referral process to get to the tertiary centers for definitive care. But also for about 43.5% of those who had poor functional outcome, we see that they required immediate intervention upon arrival, which suggested that there could be still inadequate peripheral stabilization at initial facilities. And we still know that the peripheral care remains inadequate even when transport is timely. So this has also been reported similarly in other LMIC in low-middle-income countries, where they have reported that most referred patients get to the tertiary facilities without receiving adequate interventions in initial facilities prior transfers. But also, apart from hospital arrival time, we see that there were other factors that were both protective and were risks to poor functional outcome. So we see that for children who had surgery, they had lower rates of poor functional outcome, as well as longer recovery time. And we see that for most patients who needed surgery were patients who had either had RTIs or had falls in this study, because 32.2% had succumbed. 32.2% of those that received surgery were patients who had road traffic injuries, or 31.2% had falls. But also we see that for those that received immediate intervention at the EMD, their rates are reduced by 29%, highlighting the value of early resuscitation. And mostly for patients that had hospital stays of greater than 7, it was associated with lower rates of poor functional outcome, which reflects continued inpatient support. And for other factors that were risk factors for poor functional outcome, we see that for those that were referred from either regional or specialized hospitals, they had about 40% higher rates of poor functional outcome. And this can be explained by referral bias, because we know in these centers, most patients that are referred are those either who had severe injuries and needed critical care. But also for patients that were transported by ambulance, they had like twofold higher rates for poor functional outcome compared to those that came in by public transport. And this has been explained because most ambulances are either reserved for those that are only critical cases. And for patients that had comorbid conditions, they also had a twofold increase in the rates of poor functional outcome. And for those that used insurance, we see that they also had higher rates of poor functional outcome. And this has been explained with other studies that for most trauma care, sometimes insurance does not cover the whole span of treatment, and sometimes patients have to pay both by insurance and out-of-pocket expenditure. So this can be explained by the fragmented or incomplete coverage of costs when it comes to trauma care. So coming to the strength and limitations. So the strength of this study employed survival analysis, which captured the timing and the progression of outcomes more accurately than if it were to use static measures, but also focusing on functional outcomes rather than mortality itself brings more meaningful assessment in looking at the overall pediatric recovery. In the limitation, we see that this is a single center study at a tertiary hospital at KCMC, which may limit generalizability. And there is lack of detailed pre-hospital care data of what patients had received in these referring facilities, especially on the interventions that were provided, making it difficult to take it into account when it comes to the overall analysis of this study. In the conclusion, so we see that while longer time from referring facility to KCMC was associated with lower rates of poor functional outcome, we see that more than half of referred patients had arrived beyond 6 hours, and nearly 2/3 of patients took over 1 hour to reach the initial facility following an injury. So both these longer times in referral highlight critical weaknesses in early trauma response as well as referral systems. And we see that coming to other factors, we see that both children who underwent surgery received immediate intervention or stayed greater than 7 days in the hospital had significantly lower rates of poor functional outcome. And for patients that were referred from regional or specialized facilities, those who were transported by ambulance, and those with comorbidities exhibited higher rates of poor functional outcome. So overall, both these findings underscore that while the timing of referral or hospital arrival time is important, it is not the sole determinant. So injury severity, peripheral stabilization, as well as supportive care during admission are also critical determinants of poor functional outcome. So in the recommendation, so first, I recommend strengthening peripheral stabilization because findings, we see that nearly half of referred children still needed immediate intervention upon arrival at the KCMC EMD. So this calls for improving early trauma response and stabilization at primary and secondary facilities. That means equipping frontline providers to deliver basic trauma care and resuscitation before referral, but also standardized referral protocols, because we see that their variability in referral timing and interventions both have reflected systemic gaps. So this is a call to develop clear referral guidelines for pediatric injury, but also the protocols following findings from this study, we see that they should be based on the injury severity or clinical severity, as well as the common injury mechanisms that may require immediate intervention or immediate care at tertiary level facilities. But also addressing leading causes, where we see that for this study, RTIs and falls were mostly linked by poor functional outcome, and it's a call for urgent intervention. And strengthening community-based prevention, like road safety campaigns, can enhance to improve the knowledge and awareness for these mechanisms of injury, but also enhancing triage and emergency response systems will help for these high-risk injuries. Last but not least in the recommendation is investment in the low-level facilities. We see that most of these patients come from either clinics or health centers, which we know that most of them are under-resourced or understaffed. So there is an importance of prioritizing infrastructure, trauma equipment, and training at both of these levels. So these are my references and these are my acknowledgements. I would like to thank God as well as the D43 track program for funding my studies, both my supervisors and mentors, IPH staff, my fellow track trainees, my fellow EAB classmates, as well as my family for providing support throughout this master's program. So thank you all for listening. I would like to welcome your comments and your questions. Welcome.